In 1860, there was only one psychiatric disorder. Do you know what it was? Insanity. Exactly. That was it. You were either insane or not. The whole concept of a psychiatric disorder was not even thought about, let alone written about. And that changed dramatically in the 1880s and then onward. So psychiatry was sort of born in 1880s. Early descriptions of the brain, descriptions of something that was then called dementia praecox, which is now called schizophrenia. At that time, schizophrenia, we'll get to it in a minute, but I'm just giving you a preview, was thought of as an illness involving deterioration of the brain, and that patients inevitably got worse and worse and worse, and of course back then there was very little that could be done. And that was when most people with schizophrenia ended up in what was then called an asylum, psychiatric hospital today. Since then, there's been an explosion in psychiatric research and continues to be very rapidly growing field within medicine. And now we have, as I mentioned, the Diagnostic and Statistical Manual of Psychiatric Disorders. It's a way of classifying psychiatric illness. In general, the mood disorders, the psychotic disorders, anxiety disorders, personality disorders, such that today we have identified about 350 psychiatric diagnoses or disorders. What do we mean by psychiatric? It's that which pertains to those parts of the brain responsible for thoughts, mood, behavior, and interpersonal relationships. So I've taught you how different parts of the brain are responsible for different functions. As psychiatrists, we're really not interested in the motor cortex. We leave that to the neurologists. The sensory cortex, not so much, except for the sensation of pain. We're very interested in pain because pain is an emotion that is exacerbated by other experiences like depression or anxiety. A number of other parts of the brain that really have nothing to do with these functions that we kind of let the neurologist take care of. How do we make a psychiatric diagnosis? Well, it begins, as it does in the rest of medicine, by taking a history, is what it's called. We listen to your story. You come to the doctor, you have all sorts of symptoms that have developed over the course of the last week, 2 weeks, month. You have a chief complaint. You come in saying, I have a headache. He starts asking you questions because in his mind, headache could mean just a normal everyday headache, tension headache, migraine, brain tumor, etc., down the list. He has that list in his mind, and as he's asking you questions, depending on your answers, he's ruling certain things out. He's taking things off the list and narrowing that list until gets to a point where he needs further information, further data, and that means doing tests. I've gotten to a point where it's probably one of these four. In order to know, I have to do a CAT scan. I have to do an EEG, etc. Same thing happens in psychiatry. You present to the psychiatrist and you say, I feel depressed. He's going to say, well, how are you sleeping? How's your appetite? Have you had any weight loss? How's your concentration? Are you enjoying the things you used to enjoy? How's your sexual desire? Do you have any constipation? Any anxiety? Has this affected your ability to work? Etc., etc. Right? Until we're thinking that we have a good sense of how what you're complaining of now has evolved over a certain period of time, starts suggesting the possibility of certain diagnoses. So we call that the history, or the history of the presenting illness. Now we want to put that into proper context. You're describing something that sounds like major depression, could be bipolar disorder. Oh, by the way, you're drinking alcohol every day. Half a bottle of wine? We know wine can cause depression. Is this an alcohol-induced depression as opposed to alcohol dependence plus major depression? So we're asking questions about symptoms in order to try to tease these things apart. But then we ask you about your past. Have you ever experienced these kinds of symptoms before? Oh yeah. Oh, you were hospitalized. When? We want details. How many times have you been treated in the past, and for what? What was the treatment and what was the response? 10 years ago, you had these same symptoms. You took Paxil. It worked. That's what we're going to do now. You just made my life easy. Right? Medical history. Aside from psychiatric history, do you have any active medical problems? Oh, you take Synthroid. Why? Because I have hypothyroidism. Oh, when was that diagnosed? 10 years ago. Have you been taking the medicine? Well, I ran out of it 2 months ago, and I never went back and got it. Hypothyroidism can cause many of the symptoms of depression. That might be. In fact, unconsciously, I must have been thinking about a former patient from New York. She was, how old was she? 19 or 20. And she had come down to us with symptoms of depression, and she was using cannabis. She didn't want to admit initially that she was using it every day, but we learned that later. She explained experiencing all of these symptoms that were consistent with the major depression. Was this a major depression and cannabis use disorder and something else? When we got to the medical history, she in fact was diagnosed in the past with hypothyroidism and had not been taking her Synthroid for many months. I said, now we cannot make a diagnosis because it's confounded. We cannot say whether this is a cannabis-induced depression or a major depression in addition to cannabis use disorder until we get that thyroid treated appropriately. So, got her back on the Synthroid. Within a couple of weeks, all of her symptoms were gone. Did not have to put her on an antidepressant. It was all hypothyroid. So we take a medical history. There are many other medical problems that can present with psychiatric symptoms. So we have to look, the most obvious of which is a brain tumor. I tell this story before at previous family weekends, but I attended New York Hospital, Cornell Medical Center for my psychiatric residency. And during the first year of residency, you know that as internship, I did a couple of months of neurology at Memorial Sloan Kettering. If you know Memorial, you know that their specialty is cancer. I was on the neurosurgical floor, so all of the patients were either preparing for surgery or recovering from surgery for various reasons. Could be, most commonly, brain tumors, but sometimes we'd find a patient lucky enough that it looked like a brain tumor, but it ended up being a blood clot. Well, two different patients I'm going to tell you about. One was an 18-year-old Hasidic Jew who just studied the Torah all day, every day, and argued it. And his family reported that he was extremely intelligent, and his arguments were so sophisticated that they thought something was wrong when they were listening to his arguments, and they started to detect that they weren't as sophisticated anymore. Still better than anybody else, but not as sophisticated. It was just a subtle change. They brought him to the doctor. Doctor did an exam, didn't find anything. But because they were so insistent that this was a significant change for them, that the doctor did an MRI. Metastatic melanoma throughout his brain. That was the only finding. Unbelievable. There was another patient I was involved with his care. He was early 30s, an attorney, sitting at his desk one day working, and he noticed that his right thumb just twitched a little bit. Just for a moment. He thought it was strange. He's a bit of a hypochondriac, so he went to his doctor. And most of us would just, what was that? And let it go.
A single time?
One incident, couple twitches. His primary care did an exam, didn't find anything. The attorney was very concerned. He demanded that they do a CAT scan of his head, and they did, and he had a brain tumor. Glioblastoma multiforme. Very serious brain tumor. But in just such a very specific part of the brain that was the only function that it created. And I could go on and on. There are lots of examples of that. Motor cortex, right, in the motor cortex. Yeah, it was causing a little seizure. That was the extent of the seizure. All right, so we take a medical history. We take a family history. We want to know, has anyone in your family been treated by a psychiatrist? And for what? For example, bipolar disorder. We found out that Paul's grandmother probably had bipolar disorder. I said to the therapist, contact his mother right away and find out what medicine she's taking and is it helpful? Because the chances are likely that it's going to be helpful for him as well. There's a genetic component to our response to medicine. And social history. Now, I teach the medical students, when you're asking about social history, you are starting with questions about the patient's mother's pregnancy with the patient. We want to know, were there any complications during your mother's pregnancy with you? Now, of course, many of the patients don't have any idea, but sometimes you as mothers will mention it in some type of conversation. You caused me great pain. There's a correlation in some subtypes of schizophrenia, for example, between a viral illness during the second trimester of pregnancy and the ultimate development of schizophrenia. Probably has something to do with the immune system. When you develop a viral or bacterial illness, and your body immediately produces the antibodies, the immune response, to fight the bacterium or the virus. And sometimes in the process of doing that, the antibodies cross-react with tissues of our own body, particularly the brain. And if they are attacking certain parts of the brain, it can affect development of the brain over time. And this can happen over many years' time, such that you don't see the onset of schizophrenia until late teens, early 20s. So we're interested in that part of the social history, whether birth was a C-section or vaginal delivery, any complications at birth, and then developmental milestones, walking, talking, potty training, and then attendance at school, first grade, second grade. Behavior and academics. Right? We ask questions. I just kind of discovered this myself. Now, raise your hand if you remember the name of your first grade teacher. The vast majority, right? That's healthy. Now, if you don't remember, I'm not saying anything about your brain. But I tend to see a correlation between not remembering your first grade teacher's name and you having ADHD. It's a piece of data that, of course, I put together with everything else. In the same way, by the way, that what we see, at least what I've always seen in my career, is that there's a high correlation between having ADHD in adulthood and working in sales. In fact, when I used to be in private practice, when I'd be taking a history and start getting the impression that this person probably suffers from ADHD, I would ask, actually I would tell them, I bet you have a job in sales, right?
They were probably in the class clown club.
Yes, I always ask about that actually in the history taking. Were you the class clown in first or second grade? Yeah, high correlation, an indication. So it's important to look at academics throughout and how far the person went, completed high school, went beyond that. If not, why not? Not that everybody has to, but there are explanations for the choices people make. And relationship history. And then up to the present. Working, in school, living with you when they're 25 years old. That's not good. We'll get back to that. In the process of taking the history, we've already started our mental status exam. Unlike in internal medicine, for example, we'll probably take the history while we're just sitting there at the desk, and then you'll come into the exam room and I do a physical examination, head to toe, right? In the mental status exam, we're collecting data about you as we're collecting history. We're watching your appearance. We're interested in how you're behaving in the course of the interview. Are you shaking your leg? Are you looking down at the floor? We have a patient now you may see in community meeting tomorrow morning. She refused to come into treatment today. Let me give you an example of something I had to do. Don't tell anybody. I forgot about that. She's in the apartment. We have the PHP patients over in the apartments that are in the same location as the transitional patients, because as I hope all of you come over to the new facility for the tour after this, you'll see we opened up the 4th floor where the PHP patients were to provide beds for our new detox and residential unit. So they're over there in their own apartments, which means 2 bedrooms, kitchen, living room, bathroom. And we give them a stipend to go grocery shopping each week. Part of the skills, we used to wait until they went into transitional to learn those skills, but the time restraints with the insurance companies are worsening. You know, we used to get 3 weeks PHP authorized right up front, day one. Now, as I said earlier, we get 3 or 4 days. So we have to. In fact, some of the insurance companies will ask, are you boarding the patients? You know, are they staying in your facility? Oh, no, this is supposed to be PHP. We need to know how they're acting with some freedom, how they're behaving with freedom. Are they making their own meals? If not, they won't authorize treatment. We have to show them they cannot handle that level of care before they will authorize a higher level of care. It's not the way to provide treatment. Anyway, they went shopping last night. This morning, she refused to get out of bed. The staff tried for an hour to cajole her into coming in. Now, one of the things that she was asking for yesterday, she refused to attend group, and she said that I only want to see a private doctor individually. I said, I'm a private doctor. I said, you can see me individually with all my other patients around me. Nothing worked. She's suffering from a psychosis. She's paranoid. She's delusional. I'll explain those terms in a bit. So she finally agreed to take some medicine. I gave her some medicine last night. She slept through the night. This morning she refused to come into treatment. I don't need treatment. I just want to go home. She refused to get out of bed. So I'm trying to think, what can we do? We can't pick her up physically. How are we going to leverage this? I said, I got it. I said to the coordinator, empty the kitchen of all the food. Empty those cupboards, empty that refrigerator. Remove every bit of food out of that apartment. She's going to get hungry. When she gets hungry and asks for food, we have food over at clinical. Come on over and get it. She outlasted me.
Still waiting?
Still waiting. Eddie texted me. He's over there with her now. He said, I gave her a lot of water. She was a little dehydrated. I said, yeah, we won't withhold water, but as soon as she asked for food, we got to take her to treatment. Now treatment's over. We'll try again tomorrow. So I'm hoping she comes to community tomorrow, but there's no... See, now understand this... No, unfortunately, her mother couldn't come down. Patient just came in yesterday, so didn't give her mother enough notice to come down from New Jersey. Keep something in mind. We are not withholding food. Make that clear. She has a choice to make. We'll give her all the food she wants. She's got to get in the van and come over and get it. That's a choice. Yeah, good. All right. So, we're examining behavior. That's where I got off track. Sorry, that was a tangent. During the interview yesterday morning, she was sitting with a pink hoodie, all wrapped up with her both hands underneath, and she was holding it over her mouth. So nobody could understand anything she was saying. And she was looking down. You recognize how that's all very significant behavior. It's immediately revealing something about the way her brain is functioning. That's why we're looking at signs of behavior and psychomotor activity. Psychomotor is that activity, the behavior, the movements of our arms and legs and facial expression that's related to our feelings. You can tell if I'm angry, for example. That's psychomotor activity. And the attitude toward examiner, is someone cooperative? Are they standoffish? Are they paranoid? Okay. Just to give you a hint. We do a lot of treatment by group text. So you'll learn throughout the weekend. All of the clinical staff knows everything that's happening with every patient at all times. So we can all weigh in, give our opinions, come up with the best intervention in response to some choice that a patient is making. Made it a lot more difficult before phones. Okay. Well, I missed these earlier texts, so I'm going to read them to you. First of all, Stacy knew that I was giving Stacy's our clinical director. She knew I was giving the lecture, so that I probably wouldn't see the text. So she texted Hector and said, "Please show Dr. Moran this text from Jim." Jim is one of the coordinators. So the coordinators, they are the staff members who are with the patients at all times, ensuring they are where they're supposed to be, and also helping them to not break the rules and to stay healthy, and et cetera, et cetera. You'll meet a number of them. Arnisha is her name. Arnisha is causing problems. She's now up stealing food and personal items from the girls. She admits to it and doesn't care. She is making a mess and screaming that everyone is racist. Do you have any ideas? Stacy said, "Can she take some medication?" Jim said, "All the food was removed, but the females brought in a few pieces of fruit and bread for lunch." Big mistake. You see, that just fueled her omnipotence. I can get away with engaging in these behaviors. Alyssa is one of them. She knows better. I don't know why she gave them food. Arnisha is taking whatever item she can get her hands on. Clothes, makeup, shampoo, etc. Stacy said, "How's it going? She calmed down at all?" Jim said, "She just went back to sleep. This will probably be an ongoing issue until she's stabilized. The other females are very upset about what is happening." Stacy said, "I know she's very sick, but it will get better. They are learning frustration tolerance. They now feel what their families felt when they were out of control." Yes. Now, this is a common experience for us. As long as I can get medicine into her, and so far she's taking it, this should improve dramatically within just a few days. And then we can help her more significantly. It's just as long as she's taking the medicine. Mood and affect. Mood is subjective. I have to ask you what your mood is. I cannot tell you. Doesn't matter if you're laughing or crying. And that's extremely important, by the way. If you're laughing, I better not assume that you're happy, that you feel happy, because I will miss a diagnosis. If you're laughing and you tell me that you're very sad, Or if you're crying and you tell me that you're very happy, there's a disconnection between your mood and how it's getting expressed. The brainstem is responsible for that. In fact, there are diseases that can occur. The most common one is Parkinson's disease. Anybody know anybody with Parkinson's? Yeah. Well, it's a movement disorder. Remember I mentioned the limbic system? Part of the limbic system is called the basal ganglia. Within the basal ganglia, it's called the substantia nigra. Parkinson's is the deterioration of neurons in the substantia nigra. So you see motor symptoms. You see a slowness of movements. You see tremor. You see rigidity in the muscles. But you can also see a disconnection between the mood and the emotional expression. It tends to just be out of the blue, in any context. We call it emotional incontinence. The emotions just slip out inappropriately. And it's because there's some involvement of the brain stem. Another fancy term is pseudobulbar affect, and it's common in not only Parkinson's but other neurologic diseases, and we can see it in psychiatric diseases as well. Affect, on the other hand, is what you see. It's the facial expression of the emotions. And generally, when you're talking to somebody, there's a nice tight connection between what you're seeing in their facial expression and what they're expressing in their thoughts. If there's not, that's another disconnection, and that's a finding. So actually where the word schizophrenia derives from. It's a division between the thoughts getting expressed and the emotions getting expressed. You take it for granted that generally they're well integrated. In schizophrenia, there's a distinction, to the point where you see a blunted affect. You don't see much facial expression at all. That's what appropriateness is. Speech, we're interested in rate, rhythm, prosody, perceptual disturbances, 5 senses, right? Seeing, hearing, tasting, smelling, touching, 5 senses. Well, this is the way we take information in from the environment. We perceive through our 5 senses. But sometimes things can go wrong with those processes, right? So we're misperceiving, or we're perceiving something without the external stimulus. So, I see a 40-year-old man standing here. Now you all know that there is no man. So there's no external stimulus creating the perception in my mind of him, but I see him. So it's a perception without a stimulus. We define that as hallucination. That's a visual hallucination. There can be auditory hallucinations. Tactile hallucinations. Gustatory hallucinations, taste, and olfactory hallucinations. And each of these types of hallucinations suggest the possibility of a different type of psychiatric illness. So you see more commonly in schizophrenia, for example, auditory hallucinations. In alcohol withdrawal, delirium tremens, you tend to see visual hallucinations. In amphetamine intoxication, you tend to see tactile hallucinations. In brain tumors located in the olfactory tubercle, you see olfactory hallucinations, etc. Right? Thoughts. We look at the process or organization of thoughts and the content. Organization, are thoughts organized or disorganized in general? And there are various ways thoughts are disorganized, and we have traditional terms for them. I'll give you a couple examples. A patient starts to express a thought and suddenly he's expressing a completely different thought, totally unrelated. It's as if he jumped the tracks on a railroad track. We call that derailment. The manic patient will be expressing ideas very rapidly, not necessarily associated with each other, and just one right after another. We call that flight of ideas. The traditional term, so that when we say this patient is experiencing or expressing this thought process, then the other people know what we're talking about. Sensorium and cognition, whether or not an individual is alert. Level of consciousness, alert, lethargic, obtunded, which is seems unconscious, but you can arouse him by physical stimulation, and comatose. We look at orientation. Is the person oriented to person, place, and time? You've all had the experience of disorientation to time. That is an example. Taking a nap late in the afternoon, you wake up. Is this late in the afternoon or is it early morning? And the lighting is about the same. And for a few seconds you're disoriented, but then you naturally become oriented. Oh yeah, it's 5 o'clock in the afternoon, right? The person with disorientation doesn't, just remains disoriented. Memory I mentioned earlier, remember the hippocampus, prefrontal cortex, short-term memory, long-term memory. There's something called working memory. Let me stimulate it in all of you right now. You start with 50 cents, add $1, subtract a dime. How much do you have? Okay, I just stimulated your working memory. You're picturing the 50 cents, you're calculating, you're adding the $1 to it, right? You're picturing $1. I'm making you see all of these things in your mind. You add another part of the brain for the calculation process. It's not something you need to take home tonight, not something you need to store into your hippocampus. So that working memory is actually in the frontal cortex, but a very particular part of it. It's called a dorsolateral. Dorsal meaning above, lateral off to the side. I just stimulated this part of your dorsolateral prefrontal cortex, site of working memory. There are some illnesses that impair that. Mania, schizophrenia, addiction. Concentration, your ability to focus on me, for example, while I'm teaching you, and all the extraneous stimuli, right? All the activity or the noise going on around you, you're able to shut out. You take that ability for granted. That's impaired in schizophrenia. That person is overstimulated. One of the reasons Arnisha doesn't want to come to group is too much activity, too many people talking, too much stimulation. Overpowers the brain, makes the individual feel much worse. Sometimes memory problems, sometimes concentration problems can look like memory problems. If you can't concentrate, you're not going to be able to get something into your memory, so then you won't be able to get it out when you need it. It looks like a memory problem, but it's really a concentration problem. Abstract thinking, that ability to think in terms of concepts, general concepts. It's something that we gain in development in childhood. We think in a concrete manner for the first few years of life, and then we hope that our brains are developing in such a way that we then begin to think abstractly. Think in terms of concepts like love, justice, equality. Right? These are abstract terms. Another way of exhibiting concrete thinking. Take 2 8-ounce glasses. Each of them are half full, and set them on one side of the table. You take 1 8-ounce glass and fill it completely and set it on this side of the table. Ask the 4-year-old which side has more. He'll say this side every time. Ask the 8-year-old. He'll say it's the same. He's progressed from concrete thinking to more abstract thinking. Not everybody naturally does that, by the way. We're interested in fund of knowledge. Remember the Hasidic Jew I told you about. We estimate intelligence. We're interested in whether it's normal range intelligence, above normal, below normal, mentally retarded, because it's going to inform the types of interventions we'll be able to be successful with. Impulse control is obvious. Judgment, that ability to predict the likely consequences of one's choice. And reliability. We've learned everything, we've taken a history, we've done a mental status exam, and none of it's reliable. We learn after speaking with you. You've corrected everything. The patient lied to us throughout everything. That happens over and over again. So I teach the medical students, you can't believe everything that the patient is telling you, but you can't disbelieve everything. You have to take it all with a grain of salt, right? Trust but verify kind of thing. So what are the major psychiatric syndromes? Those are the illnesses, remember about 350 of them. Not all of them need this level of care for treatment. In fact, most of them don't. These are the serious illnesses that do require this level of care. The substance-related disorders, those are not alcohol use disorder, which is what it's called now. Alcohol abuse, alcohol dependence, that's the last classification criteria set. Now, the thinking is that there really isn't enough research to justify that there's a difference between this thing we used to call alcohol abuse and alcohol dependence. That really, they're all part of the same illness, alcohol use disorder. But that's not what we're talking about here. We're talking about the way substances can cause thought symptoms, mood symptoms, behavioral symptoms, interpersonal problems, right? Alcohol-induced depression, alcohol-induced anxiety, cocaine-induced mania, that kind of thing. All of the substances can cause many of the different psychiatric symptoms. The psychotic disorders, including schizophrenia and schizoaffective disorder, schizophrenia, the symptoms include delusions, which are fixed false beliefs. Somebody believes that they are the second coming of Christ. It's hard to argue against that, but when you ask them to provide some evidence, they probably won't be able to. And if you help them to see that there isn't any evidence, but they dig their heels in, then it's a fixed false belief. And that's when we define it as a delusion. Hallucinations I taught you about. Disorganized speech. Often in schizophrenia you'll see the derailment or incoherence when they're trying to speak. They may be grossly disorganized in their behavior. This does it in a way. Those are all what are called positive symptoms. There are 4 different domains generally in schizophrenia. The positive symptoms, the ones I've just mentioned. The negative symptoms, those are the social withdrawal, decreased motivation, lack of desire, perfectly content just sitting on the sofa staring up at the ceiling, not even watching TV, just no motivation. Cognitive deficits, verbal memory deficits, visual memory deficits, executive function deficits, concentration deficits, and mood symptoms, most often depression. And so people present with schizophrenia with different types of symptoms from these 4 domains. Sometimes we'll see patients with strictly positive symptoms or those with strictly negative symptoms. Both usually have some component of cognitive symptoms. And the different subtypes, and now we are thinking more in terms of a spectrum of schizophrenias, many different types of schizophrenias. That is not just one illness. And the different subtypes tend to respond differently. ADHD we talked about earlier, symptoms of inattention, hyperactivity, impulsivity. Yes?
What's the difference between schizophrenia and schizoaffective?
Oh, thank you for asking. The present thinking is that there's a spectrum of illness with schizophrenia at one end of the spectrum and bipolar disorder at the other end and schizoaffective disorder in the middle. So it seems to be some type of mishmash of both. What you see is that at times there are psychotic symptoms and mood symptoms at the same time. At other times in that same individual, you see only the psychotic symptoms and no mood symptoms. It's the mood symptoms that tends to take it away from schizophrenia, and the psychotic symptoms in the absence of mood symptoms that seems to take it away from bipolar disorder. Because a bipolar patient can become psychotic, but only when severely manic or severely depressed. So you see the combination of mood symptoms and psychotic symptoms at the same time in bipolar disorder. You see them separately in schizoaffective disorder. You're welcome. The next slide, I think, illustrates ADHD on a practical level. Why making a sandwich can be hard. Take bread out, place bread on counter, open fridge, look for cheese, can't find cheese, look for cheese, can't find cold cuts, find cold cuts, close fridge, forgot cheese, place toppings on counter, open fridge again, grab mayo, forget to close fridge, place mayo on counter, forgot cheese, look in fridge again, find cheese, place cheese on bread, place cold cuts on bread, add mayo, close sandwich, eat sandwich. You see, the illness really has to do with that ability to predict what the next step needs to be. So you have a host of, you want to accomplish a task and you break it down into a number of steps. Now most of us do this just automatically, intuitively, right? You're breaking it down into a number of steps and then you're just following through one step after another and you've completed the task. But you're holding all of those steps in your mind at the same time. You know, if you don't have ADHD, if you want to make this sandwich, you're going to open the refrigerator, you're going to get the mayo, you're going to get the cheese, you're going to get the cold cuts, you're going to close the refrigerator, set it on the counter, take the bread out. You're going to systematically go through it, not waste one single behavioral gesture, right? How efficient our brain works. It's that efficiency that is impaired in ADHD. Always thinking just in the moment. Now, what we've learned about it is that, guess what part of the brain is not working? It's executive function, but what part of the brain is responsible for it? The prefrontal cortex, right. And so you do a functional MRI or a PET scan on these, most commonly boys, and what do you see? The prefrontal cortex isn't lighting up. So how do you get it to light up? You stimulate it with a stimulant. Now, that's for the executive function, but what if the person has attention deficit hyperactivity disorder? You're giving a stimulant to someone who's hyperactive. Does that make sense? Well, you will all understand this. The prefrontal cortex regulates the rest of the brain, right? I told you how it inhibits the craving. Well, the brainstem is also responsible for driving activity. If the prefrontal cortex is not stimulated, as it is in untreated ADHD, that brainstem is going to drive too much activity. You see hyperactivity. So you stimulate the prefrontal cortex, it's able to put the brakes on the brainstem, you see a decrease in the hyperactivity. Beautiful, huh? Now you understand it because you've learned about how the brain works.
So, are there situations you don't treat the ADHD with medication? I think you know where I'm going with this with Juliana. She's well-documented ADHD, but from what I understand, she's not being treated. Is that because of some of her other situations going on? And medication would be contraindicated?
No, that's a good question. I'm just not convinced that she has it. That doesn't mean that she didn't have it in the past. But the brain is changing throughout adolescence pretty significantly, so that people who were diagnosed in childhood may no longer have it in adulthood. In fact, a third of people diagnosed with ADHD in childhood no longer have it in adulthood. So about 2/3 continue to have it. So it may be that she did have it, and that her brain has developed in such a way that now my experience with her, I don't really see any evidence of it. It was confounded by the fact that when Jill was monitoring her, Juliana clearly put no effort into it. That's a confounding variable. And it also suggests that the test was designed in such a way that if someone is not putting an effort into it, it will let us know. So I look more clinically, I watch her like a hawk in group. I look for evidence. I see if she's paying attention. She's certainly not hyperactive. I look for other evidence of an attention problem. I don't see it, not in a convincing way anyway. Yeah.
Is there any non-medication treatment for ADHD or ADD?
Yeah, what you're doing. Writing things. Not relying on your working memory, because it tends to be impaired in ADHD. Learning organizational skills, ways of doing things automatically so you don't have to put an effort into them. I wish I could come up with some good examples of that.
What about like taking a systematic approach to do things and then sticking with it?
Yes, there are actual guidebooks for people to follow, looking at specific tasks that you tend to engage in more frequently, and kind of breaking the individual steps down for you. And you're just essentially following the tasks. So you don't have to rely on your brain to keep stimulating them into your awareness. The nice thing about treating it is that most of the time with stimulants, you see dramatic response. Yeah.
And how about, they also have non-stimulant ADD medicine, how is that?
Yeah. Not as effective.
Why do people go on it? Because they have a reaction together?
The studies have suggested that in milder forms of ADHD, in people who have not been exposed to stimulants, they have a chance of responding to atomoxetine, or the brand is Strattera. There have been some studies to show that some mild ADHD can respond to Wellbutrin, bupropion. Clonidine is used in guanfacine, which is guanfacine, which is the brand is Intuniv. Sometimes, that works through a different mechanism. It helps to decrease the. I mentioned the neurotransmitter earlier, norepinephrine. That's responsible for or involved in a lot of functions, but one is activity, and a lot of norepinephrine in certain parts of the brain will drive a lot of excessive activity. Intuniv can decrease the amount of norepinephrine, decrease activity. So how I have found it to be useful is in that person with ADHD who also has insomnia. I give them Intuniv at night. They sleep better throughout the night, but it hasn't shown itself to be dramatically effective for the other symptoms of ADHD. That's it. The mood disorders. We talked about major depression. Dysthymic disorder is a chronic, lower level type, milder form of depression. Bipolar disorder, bipolar 1, bipolar 2, so we know the symptoms of major depression. Oh, by the way, it's unfortunate that the word depression is used because there's confusion between a depressed mood state. We have all experienced depressed mood states with this psychiatric syndrome called major depression. In fact, you can suffer from major depression and not feel depressed. Instead, you would feel anhedonia, which is the lack of pleasure. No matter what you do, you don't feel any pleasure from it. Typically, in the geriatric population, when they experience depression, they'll experience more physical symptoms. They'll complain of a bellyache. If you ask them if they feel depressed, no, I'm not depressed. But this bellyache, oh, it's awful. You treat the depression, the bellyache goes away. In bipolar 1 disorder, this used to be called manic depression. So it's bipolar 1 disorder. There's at least one manic episode. In mania, you see inflated self-esteem or grandiosity, I can do anything, decreased need for sleep, so much energy, more talkative than usual, or pressure to keep talking, the other person cannot get a word in edgewise. Flight of ideas, I mentioned earlier, racing thoughts, easily distracted, an increase in goal-directed activity or psychomotor agitation, excessive involvement in pleasurable activities, often with significant risks, sexual promiscuity, spending lots of money, gambling, risk-taking at its greatest. What happens is there's not an onset of a manic episode out of the blue. What you start to see is an increase in activity such that a person feels on top of the world. We call it hypomania. I don't need to sleep so much. We'd all like to feel great with getting fewer hours of sleep so we can get more done, be more productive. In hypomania, I feel wonderful. I do not want to change this mood state. Not one person in the room would want to change that mood state. But it's an unstable state. It's not going to stay that way. That person is either headed for mania or going to drop into a severe depression. So it needs to be treated. Typically, they don't come to treatment at that mood state. You can't convince somebody with hypomania that they need treatment. No way, no how. So they become manic, and then they present for treatment. The anxiety disorders include panic disorder, social phobia, obsessive-compulsive disorder, post-traumatic stress disorder, and generalized anxiety disorder. In panic disorder, you see this abrupt onset of symptoms, including palpitations, pounding heart, accelerated heart rate, sweating, trembling, a feeling of shortness of breath, feeling of choking, chest pain, nausea, dizziness, derealization, things around you don't feel real, depersonalization, a feeling that I'm outside of my body, fear of losing control, fear of dying, paresthesias are pins and needles, chills or hot flushes, sometimes many of these symptoms, sometimes only some of the symptoms. There's we call it a crescendo onset of symptoms. So you start to feel some strange sensations, and within a very brief moments, you're having a full-blown panic attack. Most people who are unfamiliar with this don't know what's happening naturally, and of course that increases anxiety, and increased anxiety intensifies the symptoms. It snowballs on itself. Most people think they're going to die. My throat's going to close off, I'm going to die. I'll share a personal anecdote. Let's see, third year medical school. I had already done my rotation in psychiatry. Let me just give you a little background. In medical school, the way it was for us back then, a little different from how they do it now. But back then, the first 2 years was sitting in class, small auditorium, just like this, with the lecturer, teaching. You took notes, then took an exam. Third year, we actually work with real patients. We do clinical rotations. So we spend 2 months in internal medicine, 2 months in surgery, 2 months in psychiatry, a month in et cetera, for the year. And then in the fourth year, there are a couple other requirements, but most of it's elective time. So we get to pick and choose what specialties we want to spend time in. I had already done my psychiatry rotation, so I was familiar with what this was. And I was doing an elective in endocrinology out at Elmhurst Hospital. Any New Yorkers? So I was at Mount Sinai Medical School, and I was taking the subway all the way out to Queens, to Elmhurst Hospital, to do this rotation. And on my way back one day, I was in the subway, and I started to feel a little tingling. I said, that's a little strange. And then I was a little short of breath, and it felt like my throat started to close, and my heart started racing. I said, oh my God, my throat's going to close. I'm not going to be able to breathe. That's how it felt. What's happening to me? I thought I was feeling claustrophobic in the crowded subway, so I got out at the next stop, ran up the stairs to the street, hailed a cab, jumped into the cab. I said, Mount Sinai, now. On the way to Mount Sinai, I'm thinking, wait a minute, is this really happening? Or is it a panic attack? I never had a panic attack before. Why would I be having a panic attack? But I remembered this. All right. Should I go to the person who was my mentor at the time in psychiatry, or should I go to the emergency room? I'm thinking, I'm in the cab as we're headed, and I keep checking my throat. I don't know if I'm even going to make it to Mount Sinai. Finally, at the last minute, I jump out of the cab. I decide, I think it's probably a panic attack. I ran up to his office. Can you help me? I think I'm having a panic attack. Oh yeah, come on in. So we sit down, we start talking about things that are going on. A little stressful, you know, third year medical school. And I felt better just talking to him, mostly because he knew and was able to assure me that I wasn't going to die and my throat wasn't going to close. That immediately provides relief. But he gave me some advice that I would never give you now, because today we know it doesn't work. He said, take the rest of the day off, go home, open a bottle of wine, drink as much as you need to, just relax. Yes. He was Jewish, actually. Yeah. He had such an impact on me. It's very sad, though, because it was, let's see, after medical school, and then 4 years of residency, and then a couple years after I completed residency, I was at a conference talking to someone who had also gone to medical school with me, and he told me that soon after that, after we had left, he was playing squash with a friend, and he jumped up in the air and flipped over on himself and landed on his neck, broke his neck, and died. It was terrible, terrible. So what we know now about why wine is probably not a good prescription for this is that it does help, but it helps in a way that it reinforces the wine use, so that the next time someone starts to feel these symptoms, you're going to run for the bottle. And if you have the vulnerability, then it's going to turn into a habit that is going to turn into compulsive use, that is going to gradually change the brain, and suddenly you're suffering from addiction. When in fact, the effective treatments are medicine and cognitive behavioral psychotherapy. The medicine to acutely help with the severe anxiety symptoms, the panic symptoms, and to prevent another episode. But just while the person is learning the cognitive behavioral treatment, that is, how the thought process relates to these experiences. You know, the person suffering from panic disorder isn't realizing that, he or she isn't causing that initial physical sensation, right? I didn't cause the tingling, but it's the meaning I gave to it and the way I focused on it, magnified, and I started the entire process to result in the full-blown panic episode. So treatment involves learning that about yourself and recognizing the type of control one has over being able to nip that in the bud. Absolutely doable. We know, for example, that adjusting the carbon dioxide level in our blood can either worsen or improve the anxiety symptoms. And we do that with our breathing. The first thing to notice when someone is in the midst of a panic attack is that they're breathing very quickly and very shallow breaths. And that's worsening that carbon dioxide concentration.
I'm listening to you because
You're going panic attack.
I was going to tell you, try having your symptoms 35,000 feet on an 8-hour flight across the
Right.
going to Europe. So
Right.
I know exactly where you're going.
So the first thing you learn, or should be taught, is how to immediately take over and regulate your breathing. You know? Monitoring your breathing so that you're adjusting that carbon dioxide level quickly. It happens instantly. And then you teach the person how to recognize the significant decrease in anxiety just by regulating your breathing. And that gives them a sense of empowerment. That, oh yeah, I can nip this in the bud. I'm going to try even harder. And before you know it, never has to be a full-blown attack again.